is a serious disease by any standards, but 3 groups of people are more vulnerable than others: children, pregnant women, and people who visit endemic areas from non-endemic countries. The susceptibility to disease is caused, in one phrase, by reduced immunity. Millions of Nigerians have, for decades, survived through malaria, a common parasitic infection caused by mosquitoes, especially in sub-Saharan Africa. This is perhaps one of the reasons why the majority of pregnant women underestimate the impact malaria has in maternal morbidity and mortality. At this forum, the real issues are highlighted:
immunization, maternal provision of maternity services, child survival strategies, nutrition. These are all areas the 1999 Constitution, as amended, has domiciled under local government administration. Therefore, we ask today for the appointment of medical officers of health in all the 774 local government of Nigeria to head primary health care services. We believe that this will inject new impetus in healthcare administration at the level of local government area.
I'm really worried that even the healthcare providers whom you expect to be able to be the champions of this guideline, they are not adhering to the contents of the guidelines. For instance, you see a pregnant woman who has malaria going to a facility and she's offered chloroquine. For instance, chloroquine is no more being used for the treatment of malaria.
As far back as 1948, the federal government established a Nigerian malaria service to combat the deadly infection, but several challenges still persist.
The issue of poverty, because you find out that most of them, one, they don't even know the need for them to attend antenatal care, and then secondly, even when they know, access to those health facilities where they will access this care are not there.
We want to increase awareness, improve our awareness drive, that is, tell more people, the healthcare providers, train them more and more, orientate them that science is dynamic.
It appears that the manner in which the government refocuses on curbing the spread of the disease could bring about a significant drop of the mortality rate among women, especially in the rural areas.
A child dies from malaria every 30 seconds. So it is that serious. And children below 5, children under 5 years old are particularly affected. And the reason is because they have not acquired the necessary immunity, the required immunity. And then we live in a malaria endemic region. They are at risk, or constant risk, of having malaria, which is present all year through, Nigeria being an endemic zone for malaria, unlike the newborns that are protected. And the reason they are protected is because they have maternally acquired antibodies from the mother during pregnancy, which crosses to the placenta to the baby. And also the newborns are also protected because of the protective behavior of the mother, because she would want to put a newborn inside under insecticide-treated bed net. And she also could have malaria, and anytime she uses her anti-malaria drugs, some of the drugs will actually pass across to the baby through the breast milk. So that is the reason why newborns are particularly protected. But immediately after that period, the children under 5, the immunity that was acquired in neonatal period will wane off gradually, so that children are exposed. And then we also found out about the habit of the mothers. Usually when the child starts growing up to the age of 1 year and above, the care that is usually given by the mothers is not what you expected, what they do for newborns.
Malaria is actually one of the causes of maternal mortality in Nigeria. Now, this is one of the diseases that kills our women. And we actually have a very unacceptably high maternal mortality in this part of the world. And unlike the non-pregnant woman, malaria is actually much more common. In fact, the study said about 4 times more common in pregnancy. And this is because during pregnancy, the natural immunity or defenses against malaria okay, the immunity is reduced. So that makes the pregnant woman more prone. And this has implications not only for the pregnant woman herself, but even for her unborn child. So malaria is more common in pregnancy, it's more severe in pregnancy, and its manifestations are sometimes unusual or atypical in pregnancy. And it has a lot of effects on both the mother and the unborn child. It can result in miscarriage or loss of the unborn baby. It can make the baby not to grow well, what we'll call intrauterine growth restriction. It can result in prematurity. It makes labor to come before time, what we'll call preterm labor. And the baby is born premature with a lot of challenges. In the mother herself, it can make her have a low blood level, what we'll call anemia. And it can result in other severe manifestations like convulsions, losing consciousness, what we'll call cerebral malaria. It could cause her to have low blood sugar, cause weakness, cause yellowness of the eyes, problems with the kidneys, abnormal bleeding, so many things. And worst of all, it can result in stillbirth for the baby and death for the mother.
In reply to this threat, the World Health Organization has come up with a three-pronged approach to the prevention and management of malaria in pregnant women and children under 5 years. The insecticide-treated net, intermittent preventive treatment, and effective case management.
For those who live in the low areas, because of the stagnant water, it's the habitat for malaria, then the children are already malnourished, they don't take good food, and poor water supply, then malaria coming on that kind of child would easily progress to be complicated, to become severe, then not even having the money to access proper medical care. In our environment, they first start with the herbs. By the time they take the popular agbo, there is an agbo that is known for malaria. They take that, and by the time the child goes into hypoglycemia, then they rush the child to the hospital. So those kind of children are received already in a compromised state. But if you look at a child who comes from a medium to high socioeconomic status, probably has a health insurance, and lives in a netted house. If that child peradventure has malaria, the first thing is the child has fever, the child is going to school, and the child is going to tell the parents that I'm not feeling okay. So, it's nipped in the bud, the child is taken to the hospital, the child can be tested, the child can have medications. In the same vein, this pregnant woman, her survival or her risk to malaria is also dependent on her socioeconomic status.
People from more comfortable economic backgrounds did seem to be more equipped for malaria.
The house is net. We flea the house regularly. That is very, very important. We flea the house and we make sure the environment is tidy up. At times I do fumigation. There's a gutters dry. Then I will select the government help the masses, as the health centers. They should go around and fumigate the gutters. You see, mosquito breathe where there's water. So stagnant water, the waters are not moving. Where there's mosquito. So the government can go around to help the masses. In the 70s, when I was a little boy, the health centers go around. When they fumigate our area for 1 month or one month, we see mosquito.
So simple. Every 3 months, I use anti-malaria drugs. So that prevents me from having malaria.
Fleet my room every day. I used to sleep under mosquito nets. Sometimes I used to use fleet. Then I make sure that the gutter around me, I used to clear it. I don't like medicine anyway. I don't like drug.
Hardly fall sick. Since I can't remember, it has been long since my childhood. I've never been in hospital and take a bed.